You make tough calls when caring for acutely ill and injured children. Join us for strategy and support through clinical cases, research, and reviews, and best practice guidance in our ever-changing acute care landscape. This is your Pediatric Emergency Playbook.
Welcome to the Playbook. I'm your host and coach, Tim Horechko. We always need a backup. Whether it's in securing an airway or troubleshooting a difficult presentation, or obtaining vascular access. There's some things that, once we've made the decision to do them, we simply just have to get them done. Obtaining peripheral IV access in some patients can be difficult, and in others, it's just plain impossible to do in a timely fashion. There may be many factors that come into play. The experience of the operator, the urgency of the situation, or patient characteristics, like maybe the child is in shock, or we've tried many times, or the veins are sclerosed because of chemotherapy or chronic illness. You may just have a little patient in arrest or peri-arrest, and you need to get meds into him now. Intraosseous devices have been around for some time, and thankfully, they're much more universally available. For a while, I was just happy that someone knew that I/O was an option and that I/O equals IV. Now that, collectively, we have more experience, we get more questions. What size to use? What labs can I draw from an I/O? How long can it stay in? And many, many more I'm sure you've heard yourself. Now, got a question for you. You're a great driver, aren't you? Anyone you ask, of course, is a better driver than anyone else they know. It's just our human nature. Just because a skill is commonly shared doesn't mean it's commonly mastered. And things that we take for granted, they're almost automatic for us, will come to a screeching halt when we have to troubleshoot or when someone asks us a particular question we can't quite answer. Today, let's go over some pearls for the actual insertion of the intraosseous device, and then go through a frequently asked questions list to get us driving that bone needle at top speed. First, the options. For a long time, we only had manual I/Os like the Cook or the Jamshidi or the Illinois. I remember as a resident, we really only had the Jamshidi readily available, and it was always a pain. First, you have to set manually the depth and do a very inaccurate and very inconsistent guesswork. Then, you have to screw in the needle, pushing hard enough, but not too hard, all while everyone in the room looks at you like some heartless barbarian while the patient winces or screams. Now, if that's all you got, then go for it. We'll briefly review some manual tips later. Based on a Twitter poll I sent out just before sitting down to talk with you, it seems that most people have access to or are using the Easy I/O preferentially, so we'll spend most of our time there, but I'll mention a few other devices like the bone injector gun. Okay, you have a critically ill neonate, a young child, adolescent, or adult, and you need access now. PALS will say that after 2 attempts at IV, then I/O is the way to go. Use your best judgment. A patient comes in ill, very ill. Everyone in the room is just on this side of panic. You grab your Easy I/O. You test out the gun. It works. You rummage around for the needle. Oh, which needle? In the rush to do something, you can't even really see the small printed description for each. How much does this kid weigh? I don't know, he was just rushed back. I don't want to use something too small, it won't get into the medullary space, or something too large, it'll harpoon that kid and it'll have me squirting saline through his leg and onto the gurney. What to do? If you remember nothing else, remember this. Pink is for pediatric. Blue is for the big boys. And yellow is for the big birds. What does that mean? The pink needle is for the typical pediatric patient, 3 to 39 kilograms. So the pink IO needle will work for the septic neonate in extremis, up to the kindergartner or young school-age child. Now, you could say, well, a school-age child of 9, 10, or 11 years of age might not quite reach the 40 kilograms, and that's true, but in my experience, the pediatric IO needle is pretty small, and when we're talking about reaching the intramedullary space, it's better to have a little more needle to work with than less, especially in the pudgier little buddy. So, pink, pediatric, 3 to 39 kilos, that's 15 millimeters long. Okay, what about the preteen, teen, and normal-sized adult? That's the big boy blue needle, 25 millimeters of length for 40 kilograms and higher. And finally, you have the yellow big bird, 45 millimeters long, so almost double the size of the adult blue needle. The manufacturer just says this is for patients with, quote, excessive tissue, unquote. So do with that what you will. It's a big needle. It's really for the morbidly obese who really have a lot of extra padding. Okay, pink for pediatric, blue is for the big boy, and yellow is for the big bird. Got it. But what is the goal here? Knowing the needle sizes are 15, 25, and 45 millimeters long, it's helpful as a starting point, but how do we apply that to the patient in front of us? The full truth is that they're weight-based. It's actual body weight, so you have to adjust your approach accordingly. How do we do that? Well, remember those little black lines on the needle? They're reference points. Let's talk about how to use them. One big problem we have when we're trying to place an IO, especially in larger children, adolescents, or adults, is that the needle may not be long enough. When you have the needle loaded into the driver, you've found your landmarks, you've cleaned it with antiseptic, and you're ready to go for it, take one short half second. Look at the black marks on the needle as you place it in the tip of the skin. The pink pediatric needle only has one black line. The blue adult and yellow large adult needles will have several. Whichever needle you're placing, when the tip gets to the bone and you've got purchase on the periosteum and you're ready to drill, at this crucial point, you want to look up and see at least one black line above the skin. So the needle tip is pierced through the subcutaneous. It's touching the bone. Look for that little black line just before you drill. The reason is that as the needle passes through the soft tissue, you'll still need to account for the depth you'll need to clear the cortex of the bone and ensure that the bevel of the needle is safely in the cancellous bone, where fluids and medications will readily be delivered to the systemic circulation. The flip side is this, and I'm sure you've been in this situation. Maybe you see the school-age child who is pretty husky. He's sick, dehydrated, and you need access now. You rightly choose the pink pediatric catheter, thinking based on his age, he certainly should be under 40 kilograms. Except, even in the pretibial space, where we all are relatively svelte, your needle, it meets the bone, but the black line is already buried into his generous subcutaneous tissue. So you have two options. One is drill, baby, drill. And maybe if you hub the needle, really get it in there, make that subcutaneous tissue dimple, maybe you can still reach the cancellous bone. Or you notice that there will just not be enough needle depth to get through the cortex, and mid-procedure, you stop and call for the adult blue big boy needle. You place that one, and right as you reach the bone, you still see at least two black lines. In this case, you drill through the cortex, you feel a give, and you stop there. No need to hub it. This is important because IO needles are not quite a one-size-fits-all. You still have to use your judgment. If you chose the first option and continue with a needle that was too small, you may get lucky. You may get bone marrow back when you aspirate, and you may be able to flush that first saline flush. You feel pretty good about yourself. Yeah, you just did that. Until a few minutes later, the smiles from the nurses turn into a meh face when the child is repositioned, or the needle gets jostled, or that 1 millimeter of clearance no longer cuts it. There's no flow and resistance increases. Or worse, it looks like it's in. You're still using it in an altered patient, and you don't realize until later that the vasopressor you're giving is now in the subcutaneous tissue. Not so nice. No more high fives for you. The moral of the story is that with all the excitement, with all of your focus and gumption and eagerness to drill, baby, drill, take just a moment to feel for the bone and look for that black line. Got to bone, still have a black line? You're good. Got to bone and you've lost your last black line in the sea of soft tissue? Upgrade that needle, my friend. You'll be glad you did. No matter how long that needle is, all of them are 15 gauge. That's going to give you pretty great flow rate. Since we've gotten into the mechanics of insertion, we should talk about where you're going to place the IO, what site on the body. You've got a few choices: the humerus, the femur, and the proximal and distal tibia. Okay, we can talk about how awesome it would be to place a sternal IO, but that requires an entirely different needle. Most places don't stock them outside of the military, and if you use a standard needle on the sternum, it will be the messiest central line you'll ever do. For our purposes, we'll leave the sternal IO alone. Let's start with the easiest and most common site, the proximal tibia. With the leg extended, look at the medial aspect of the proximal tibia. In the older child, you'll feel the tibial tuberosity. Go 2 centimeters medial and 2 centimeters below the tibial tuberosity. That's your site. If you can't palpate the tibial tuberosity, find the apex of the patella and just go 3 centimeters below. In infants and small children, you'll want to go 1 centimeter down and 1 centimeter medial. Now, to simplify all of this, all you're trying to do is find the flat part of the bone to place the IO. That's it. We look for a flat surface because it's the most reproducible and reliable spot. Don't obsess, don't measure, just know what you're looking for. The flat surface medial and distal to the tibial tuberosity, and you're in. So let's go from start to finish. Prep the area with alcohol, chlorhexidine, or betadine, whatever your institution favors. Once you've found your site, clean and don't touch it again. Load the needle on the driver. Remove the small plastic cover on the needle tip. Stabilize the extremity with your non-dominant hand. Aim the needle at a 90-degree angle to the flat surface of the bone. Push that sharp needle through the skin until you meet the bone. Now remember, you should still be able to see what? What kind of line? A little black line to give enough depth to make it through the cortex to the cancellous bone. For adolescents and adults, drill, feeling for the give, and in them, advance the drill another 1 to 2 centimeters. In children, you have to be careful not to go too far. That's why feeling for the bone, verifying the black line, drilling in just enough is important. In adolescents and adults, we often have to hub the needle to be able to go that other 1 to 2 centimeters after you feel the loss of resistance. In children, go just enough. That is, in children, as soon as you feel a loss of resistance, that's plenty, since naturally you'll go far enough to get where you need to. The needle driver does the work. don't make a habit of advancing further in infants and small children. Okay, hold the hub in place while you put the driver aside. Hold on to the hub and twist the needle off, and be careful not to poke anyone as you safely dispose of the sharp needle. If you have the stabilizer dressing, put that on now and then connect to the tubing kit. And make sure that tubing kit is primed with saline before you start. You can infuse the bone with lidocaine, and more on that in a moment. Draw back marrow, just to be sure. Remember, it's nice to be able to draw back, but it's not required. The proof is in the pudding here. Flush. You should feel the fluid go in more slowly than you would if you were to do it in IV, but you shouldn't feel major resistance. Be sure to look for extravasation and feel behind in the calf, especially in smaller children, to be sure you didn't go through both cortices and that you're not delivering fluid into the posterior tissues. Okay, that was pretty straightforward, and you've done this many times before, I'm sure. The distal tibia is a nice choice as well. It's the same procedure. You find the medial malleolus now, and you're going to go 3 centimeters proximal in adults and 1 to 2 centimeters proximal in children. Remember, you're just looking for the flat portion of the bone. Be gentle and judicious with infants and young children. Drill just to loss of resistance. In adolescents and adults, drill until loss of resistance, and then another 1 to 2 centimeters. All right. Truthfully, most people have at least one tibia. It's an easy place to go. When would you even consider another site? Well, maybe the tibia is broken. Well, you can use the other one. Okay, fine. But you and I, we're all about options, right? Here's another one. The distal femur. This site is really only for our pediatric patients. Adolescents and adults, we just have too much developed tendon and muscle for it to be a practical option. In neonates, infants, and young children, find the superior border of the patella. Go 1 to 2 centimeters above that, midline. Now here's the trick. To insert the IO into the distal femur, you want to aim about 10 to 15 degrees cephalad. This is to avoid damaging the growth plate. Otherwise, it's the same insertion and securing advice that we talked about. With any procedure and in any resuscitation, we want to make sure we're looking at the patient and the situation as a whole. The lower extremity is best for a medical code. Maybe the septic patient or the seizing patient. But be careful in trauma. If you have a concern for abdominal or thoracic trauma, fluids poured into the lower extremities may just end up in the abdominal cavity. Think of another site, which leads us to the head of the humerus. This is a good choice in older children and adolescents and adults. You get fast access to the central circulation with a humeral IO. In infants and young children, the greater tubercle isn't developed, and it's really impossible to palpate. Since that's our landmark, it's a tough call to place an IO in the humerus of a young child. Remember also that the humerus is a non-weight-bearing bone. It's softer, and it takes more time to develop in comparison to the lower extremity bones that are constantly getting their insertion sites stressed by walking and bearing weight. So in, say, the 8 to 10-year-old and up, and definitely in adolescents and adults, consider the humeral route. Since there's more muscle mass in this site, you want to think about using the longer yellow Big Bird needle, the 45 millimeter needle. The target is the most prominent part of the greater tubercle of the humerus. Now here's where it gets tricky. You need to get that arm in the proper position so that you know that you're accessing the greater tubercle. Well, how do you do that? Have the patient place his palm on his belly. That's it. What does that do? Now you've internally rotated the arm so that the greater tubercle is anterior and accessible to you. The classic teaching is that once the patient has his hand resting over his umbilicus, take your palm and gently slap it on that spot. The flat surface anteriorly is now where you're going to focus. The part that feels like a ball is where you're going for. Some people call it the golf ball on the tee, so the humeral head above the surgical neck. You're going to drill in at a 45-degree angle. Aim for the inferiolateral border of the scapula. Since this site requires you to be correct in 3 dimensions, it's sometimes hard to visualize. Take a look at penplaybook.org to get a visual. Let's say your driver runs out of power, or it's grown legs and walked away, or you only have manual IOs. What then? The manufacturer of the Easy IO device also sells an accessory that looks like a small doorknob that you can use to insert the Easy IO manually. Interestingly, the reps will tell you that you can still insert the Easy IO with the needle only, so there's that. The most common scenario for manual insertion is not with the brand Easy IO needles, but with the tried and true traditional Jamshidi, Illinois, or Cook IOs. In my training, we only had these. It was not until later that the Easy IO was available. Now, if I had my choice, I'd pick the Easy IO because I think it's less painful and more accurate. Now, I don't have any relationship with them, just giving you my 2 cents. If you're in the position where you only have a manual IO, it's still a great tool. Here's how to use them. The Jamshidi is a little blue device that you drive in manually. The Illinois is a very similar device, lighter blue with a bulkier frame. For either, first, unscrew the top to expose the stylet under the cap. Then you'll have to adjust the flange distally to expose the appropriate length of needle. The Jamshidi really is a one-size-fits-all. It's not foolproof, so you have to decide ahead of time how much needle to use and how much needle to expose. Honestly, before the Easy IO, we would just estimate, and probably pretty poorly. Since a lot of research and human factors design has gone into the Easy IO, we can use their estimates. When working with the Jamshidi, expose 15 millimeters for a child under 40 kilograms, 25 millimeters for a child over 40 kilograms, and 45 millimeters for excessive tissue. You prep the site as you would otherwise and grip the distal end with your first 3 fingers. Hold the needle perpendicular to the skin, pierce through the tissues, get purchase with a bone, and rotate clockwise and counterclockwise with gentle pressure until you feel a loss of resistance. Then, you remove the stylet, attach the syringe, and pull back and flush as usual. A few tips for the Jamshidi. Since you are in complete control, you have to be careful to maintain your good form throughout. I think there's a tendency for people to rock the needle slightly off axis when they're trying to rotate it. You'll either go in at an odd angle, it's not quite perpendicular, or worse, you bend the needle, or you efface the bevel, ruining the needle and causing lots of pain. Make sure you stay perpendicular, gentle but firm pressure as you rotate it in. I guess if you could LP your bone, this would be the setup. The nice thing about the Jamshidi is that you select your depth so that you can hub the plastic housing to the skin, which makes it a little bit more secure. The Cook catheter IO is really a long needle with a handle. There's no pre-procedure estimation. This is as old school as it gets. You screw in the needle just like the Jamshidi, but just as deep or superficial as you decide. You end up with something that looks like a harpoon LP needle sticking out of the bone. It can easily be dislodged or knocked over. You have to use bulky dressings to protect it, and don't expect it to last past the initial resuscitation. The downside of either of these, of course, is that any manual insertion technique, you're going a lot more slowly, and it's a lot more agonizing than when you use the drill. The manual technique is probably best used in obtunded patients for that reason. The nice thing about the drill is that it's so fast that by the time you finish, the patient barely is aware of what happened. One more thing to mention. It's a hybrid manual automatic, the bone injection gun. It's used mostly for pre-hospital care, and it's like an EpiPen for your bone. You just follow the easy directions on the side, place the device up against the skin, hold firmly, pull the trigger, and go for it. In my experience, it's great in that it's easy to use, but the downside is there's really no control or judgment. It's a bit of a coin toss. Also, you have to be careful not to get recoil of the gun. The noise and jolting action can be a bit upsetting to the child as well. Now, all of this talk about pain on insertion has us thinking, well, what about it then? There isn't much use for local anesthetic here. You're going to give a poke either way, and the super sharp IO is a cutting needle. There really isn't too much pain with the subcutaneous insertion. Even going through the bone doesn't really hurt as much as you would think. The distracting pain gate method using the vibrations of the driver usually distracts people, and it's especially if you're using IO, the easy IO, it's so quick. What really can be uncomfortable for patients is the infusion. Now, to counteract that, you can infuse some lidocaine into the bone and let it sit for a few minutes in the conscious patient. The pros and cons of this. If it really is a patient who really will be very upset by an infusion, then maybe you have time to keep looking for an IV. Or if you have time to wait for lidocaine to sit there, infuse, and try to numb up the bone marrow, do you really need an IO? Now, these are just questions. I'm sure there are many situations where this will come in handy, but most of the time for me, I use an IO on people who don't care that I'm using an IO on them. But in the case where you want to try it, you can wait a few minutes, or sometimes you have a patient who spontaneously and suddenly just doesn't tolerate your using the IO. You can use 2% lidocaine. That's preservative-free, and of course, epinephrine-free. It's the IV lidocaine. You inject 0.5 milligrams per kilogram up to 40 milligrams, and you wait a few minutes to let that settle in and try to anesthetize the cancellous bone so that when you have ongoing infusions, it's just a little more tolerable. You've placed the IO. You internally high-five yourself. You have no other access, and you'd like to get some lab information right now about this critically ill child. Can you use the blood aspirated from the IO for laboratory work? Do you get any legitimate results? The answer is yes and no. Some lab values from IO correlate very well with those in the peripheral blood. Some are terrible. You could try to hypothesize which ones would work, but there's really no intuitive rhyme or reason for them. For an extensive list, you can always look it up, but I know you. You're like me in this way. Just give me something I can use today. So we'll go over the take it to the bank high correlation labs, those with moderate correlation, and those with don't even bother. First, the for sure good correlation, IO to IV. Let's go for the easiest one first. Glucose. If you need to get a quick sense of why this child is seizing or altered, boom, you have a glucose from your IO that correlates very nicely with the same lab that would have been taken Makes sense, right? You shouldn't somehow have a higher or lower blood blood glucose level from the aspiration site, right? Now, another easy one is the pH. It correlates well for our clinical purposes for the same reason as glucose. Those two are the for sure labs that all studies will agree on. The issue is that there have been various studies over the years, and you'll see mixed results in the literature. I tend to pay more attention to studies that use the Bland-Altman methodology in finding the best agreement. Oh, what is that, you ask? Well, even if you don't ask, here's your daily dose of stats. The Bland-Altman plot is a difference plot. So instead of plotting the IO value on the x-axis and the IV value on the y-axis, the Bland-Altman procedure plots the average of the two measurements on the x-axis and the difference between the two measurements on the y-axis. This gives a more sophisticated look at the data and helps us to take into consideration the outliers. For example, on the x-axis is the difference between the two measures. It's variability between those two methods, between the two sources. The y-axis plots the actual difference. So it helps you to see how much the values vary given the range of possible values. In other words, blah, blah, blah range. What's the bottom line, Tim? The bottom line is that this graph is a scatter plot to give you a sense of how close the IO lab values come to the value that you would get from peripheral blood. Hemoglobin and hematocrit, they're moderately correlated on this scatter plot. Be careful though, a WBC and platelet count, they don't correlate very well IO and IV, so you can't use it as a formal CBC. Just the hemoglobin or hematocrit. Now, sodium is the dark horse here. The difference in measures, the x-axis, is a bit wide, but when correlated to the average between the two measures, we find a moderate correlation by Bland-Altman analysis. So we really can't use the IO sodium value to replace the IV value, but honestly, we never would. What we're trying to find out right now at point of care is whether or not there's extreme hyponatremia that could explain, the seizures that are resistant to all the benzos you've been giving, or why that patient just seems to be altered no matter what I do. Remember, the IO is really used for the initial resuscitation. It's not for definitive care. And so the labs that you use from it are really just a roundabout, quick idea of where you're going. It's nice to know that the pH, the glucose, and even the sodium from an IO, you can process it in maybe a point of care machine, and you can use it to make clinical decisions, at least initially, until you have more information. Now, there is a longer list of things that correlate better, like the creatinine correlates really nicely, the BUN, the lactate, and the chloride, but none of those things will change what you do right now in a resuscitation. Even an elevated creatinine, if I happen to know it, it wouldn't stop me from giving contrast in, say, a trauma patient. This takes us to labs that we really should not use from IO. Potassium, no correlation. Calcium, it's all over the place. And of course, we mentioned that the WBC is usually higher in the IO sample and the platelets are usually lower. The summary here is, don't use the IO blood to replace proper labs sent from an arterial or venous source. But in the child or adult who is critically ill and you have no other blood, you can use the pH, glucose, and sodium to help you with the initial resuscitation. Okay, are we good here? Imaging? Really? You want me to go there? Okay, for you and only for you. But just this once, all right? We're still in the situation where we have a critically ill child and there's no other access. Perhaps this is a trauma patient. We need to give IV contrast. We know that for medications, IO equals IV. But is that true for imaging? Well, why wouldn't it be? The rapidity of access to vascular compartment is pretty impressive, but there are technical considerations with the timing of the contrast, of course. And then you think about the pressure that's needed to inject the contrast. What's the evidence say about this? Well, there isn't a large body of evidence to tell you that for sure IO contrast is equivalent to IV contrast. But we do have some evidence to show us that with IO, we can get reasonable results. For trauma patients, we do contrast tomography, and to be honest, the timing of contrast in this case is important, but we can see what we need to see even if the timing is a little bit off. The limitations, of course, here would be that maybe if you're looking for a contrast blush in the spleen, an IO study may or may not be as accurate as a study done intravenously. So, in general, if you really have no other access, you can use even the tibial IO. If possible, though, the humerus may be better from a timing standpoint. In one study of healthy volunteers, contrast media in the proximal humerus took 2.42 seconds to reach the superior vena cava. They verified this by fluoroscopy. Now, remember, one other practical issue is that the power injector from the CT has to be attached directly to the IO hub, not to its extension tubing. This may not be a commonly known detail, so you'll just have to be that resource for your CT tech. Now, once we start talking about meticulously timed studies like pulmonary angiography for PE or CT angiography of the aorta, then the evidence is really not so robust. We're talking case series at this point. Again, did you choose to be in the situation where you only have IO access and a critically ill child? No. Did you do everything possible to get an IV? Of course you did. Will you ever be in this situation? Probably at some point. So you do the best you can with what you have at the time, but you understand the risks, benefits, and limitations, just like in anything we do. And just to finish up our list of limitations, of course, we don't want to use IO for fractures of that bone, like we mentioned before, or infection or cellulitis at the site of insertion. Think twice before you place an IO in a bone that has hardware in it, from a previous orthopedic surgery, for example. And this usually isn't the case for us, but don't use the same bone twice in a 48-hour period. All right. At this point, I think we've reviewed a lot of stuff that you already know. It's good to refresh. Let's do a rapid-fire question and answer for all of those annoying miscellaneous questions that you'll get. You know, the ones that you get asked when you're on the phone, or you're trying to get to the bathroom, or you're trying to find the epiglottis and place the tube. You know what I'm talking about. First, what are the possible complications of using IO? You usually get some flack from an inpatient team who may not be familiar with IOs. Here's your chance to help get them with the program. Now, extravasation happens. It's usually only when we place them incorrectly. Remember your black line and loss of resistance that we talked about, as well as getting a good flush. But, of course, they always bring up what? Osteomyelitis. Osteomyelitis is very rare. In one meta-analysis, the rate of osteomyelitis from IO insertion was less than 1%. In fact, it was 0.6% to be exact. What about long-term damage to the bone from the various meds that we're pushing? We have data from even the 1940s on to show that there's really no long-term damage, especially from short-term use of the IO. Some early data warned against hypertonic saline or the chemotherapy drug adriamycin, but hypertonic can sclerose small veins too, and I really hope that you're not giving stat doses of adriamycin in the ED. What about fat embolus? No, it's not a thing. Air embolus? Well, sure, just like an IV, so prep your tubing. Well, how do we know this? Is somebody keeping track of all these complications? Well, yes. In fact, the EZ-IO company keeps track of all the reported complications that they are given globally. What about compartment syndrome? Well, it can happen with IV just as easily as with IO. Basically, if you're not in the cancellous bone, you can leak into the tissues and cause compartment syndrome. Hence, taking the time to place it well, monitor its usage, and getting an IV and using that whenever you can, maybe later on down when the child is more resuscitated. Luckily, to date, there have only been 8 cases of compartment syndrome from IO use in pediatric patients. In every case, the needle was either malpositioned or they used it for a long period of time. They used it for days and days with agents that cause irritation. So if you place it well and use it for resuscitation, you're good. You have more questions? Wow, you are on fire. Okay, shoot. Can you use it for MRI? No, metal. Come on. Next. Can you use it in patients with bone disorders like osteoporosis or osteogenesis imperfecta? Yes, but think twice. Do you really need an IO? Is it really worth it? If you have to ask yourself that question, then you should think twice. Otherwise, just resuscitate that kid. Can you use the IO in a child with avascular necrosis? Well, yes, but if the bone vasculature is abnormal, then administration of fluids or meds may not happen as you expect them to. So avoid that bone if you can, but yes, it is possible. Can you use the IO in burn patients? Yes. In fact, it's a great use of the device. Try to find a place that is not burned, but if you have to, you can place it through the burned skin as long as the bone underneath is not burned. Okay, Tim, I messed up the proximal tibia insertion. Can I just use the distal site? Or vice versa? No, don't go into the same bone twice. Remember, it's not recommended to use that same bone within 48 hours. Okay, can I walk with the IO if it's in my tibia? Okay, you can, but should you? No. How do you remove an IO? Okay, this is a good one. Twist it out clockwise while pulling directly out. Make sure not to rock it back and forth. Okay, Tim, I just tried that and the plastic hub broke off. Now what I do? All right, Hercules, here's what you do. Grasp what's left of that with a Kelly clamp and twist it off clockwise. Just use your human strength now, okay? Another question. Does the site leak after I take it out? It may, but direct pressure for 1 to 2 minutes will help form a clot in the tissues and stop that slow ooze. You don't need any special dressing after the removal, and usual monitoring of the site for the next day or so is helpful. Make sure that the patient knows to look for ecchymosis, for edema, for pain, or for fever, all of which are very unlikely. Okay, one last question. I'm ready. Make it a good one, please, this time. What? You went there, didn't you? Yes, if you find yourself in a hyperbaric chamber and you happen to have no access, you can place an IO, but there's a catch. You have to use the manual method. In hyperbaric chambers, under many, many atmospheres, the risk for creating a spark from the device is just not worth that risk in an oxygen-rich environment. So, manual it is. Okay, are you finished? Okay, good. All right, let's bring it all together. After trying at least twice to get a good IV, if you need immediate access to resuscitate a child, go for the IO. Choose the site wisely, prep, watch for the black line, and feel for the loss of resistance. No flush equals no flow. Be careful that you feel confident in your placement before you just let those fluids go in and walk away. Monitor continuously for dislodgement or extravasation. Labs, pH, glucose, and sodium. They're good to use for the initial clinical assessment in a resuscitation context. Everything else is mostly bogus. You can use the IO for CT for trauma. Go for the humerus if possible in older children and adolescents. When in doubt, pull it out, but otherwise, drill them if you got them. I hope all of this helps make your next shift a little easier, or at least the miscellaneous questions a little less annoying. Share what you know with your colleagues, encourage each other, and make your little sphere of influence bigger, kinder, and better to live in. Until next time, remember, you are the champion for the child in front of you. Take care.
Thank you for listening to The Playbook. We welcome your comments, questions, and feedback. Email Tim at coach@pemplaybook.org or drop by our website for show notes and more strategy at pemplaybook.org. See you there.